Hi guys, welcome everyone to the PW method. I'm Dr. Patil, and so here we are going another quick quiz on the topics that we have covered so far in the Reed Harrison series. So we have 7 questions today, and hopefully we should be able to finish that in another maybe 10 or 15 minutes. So let's start quick. Okay, so just give me a thumbs up if you're able to hear me loud and clear. Okay, cool. So let me start with the very first question. This is a question number one. Which of the following are not cough receptors? Simple, straightforward question. In fact, cough is the first topic that we did in the Reed Harrison series. And we all know that cough is the most common, one of the most common complaints that we see in our OPDs and in patients. So knowing everything about cough is important. Which of the following is or are not cough receptors? So what do you think should be the answer here? So we have options A delta, TRPV1, P2X3, or none of the above. So let me know in the chat section. Nilanjana, good evening. Good evening. So which of these is not a cough receptor? So we had studied about the cough reflex. Basically, cough is a reflex, right? So it has to have sensory receptors. They take the signal and then through vagus nerve, it reaches the centers. And from the center, the efferent again travels through vagus and phrenic nerve. We contract the abdominal musculature, diaphragm, intercostal muscles vigorously, keeping the glottis closed, and then everything released. Okay. Brock Lesnar, P2X3 is a cough receptor. It is a cough receptor. So, Tapa Samantha, good evening. So, please remember, let me take you through the notes for the cough receptors. So, the cough reflex has receptors which includes chemoreceptors and mechanoreceptors, right? Chemoreceptors are primarily TRPV1 and TRPV4. We call them as vanilloid receptors. They're usually stimulated by the chemicals. And most importantly, in the laboratories, to initiate cough for study on the cough suppressant drugs and all, we actually use chili powder, right? Because it contains capsaicin, which is the strongest known stimulant for these receptors. And whenever there is a stretch of the airway, like you see in patients with interstitial lung disease, why do they cough? Because mechanical stretch of the airway. So P2X3 acts as a mechanoreceptors. So once these receptors are stimulated, the signal travels through the cough center located in the medulla through A delta and C fibers of vagus nerve. So A delta and C fibers are types of nerve fibers. They are not receptors. And then the cough center in the medulla, that is nucleus tractus solitarius, processes this information and sends the efferent signal through glossopharyngeal, vagus, and the phrenic nerve. So with this output, we contract the diaphragm, intercostal muscles, abdominal muscles, keeping the glottis closed, build a lot of pressure inside the lungs, and then suddenly we release the glottis so that everything comes out in an explosive expiration, and that's what we call as cough. So now getting back to the question, what makes the right answer here? TRPV1 is a cough receptor. P2X3 is also a cough receptor. A delta is a type of nerve fiber or a neuron. So this is not a cough receptor, and that becomes our answer. Nilanjana, good, very good, very good. Now next, match the following. So on one side we have the color of the sputum, the other side the organism. Okay. So now rusty colored sputum. What would be the right match from the organisms available in the option? Rusty means the iron when it gets rusted, kind of brownish color it gets, right? So kind of that colored sputum, rusty colored sputum. Where do we get rusty colored sputum? Rusty, yes, Nilanjan, absolutely right. The rusty colored, Sutapan, no. Rusty colored we see in streptococcal pneumonia. So the right match would be strep pneumonia. Okay. Then second, red currant jelly sputum. Red currant jelly sputum. Kind of looking like the jam. Sputum looking like the jam. Where do we get that? Red currant, yes, right. Red currant in Klebsiella pneumoniae. Klebsiella pneumoniae, we get red currant jelly kind of sputum. And then where do we get bluish green? Obviously, we're left with only one option. That is Pseudomonas aeruginosa. We get bluish green colored sputum, right? So even getting a little bit of history of the nature of sputum can help us to reach the diagnosis clinically. Obviously, culture and microscopy will be the best investigation to identify the organism. Okay. Now, this is one pharmacology question. Which of the following is a P2X3 antagonist used for treatment of cough? Codeine, dextromethorphan, benzonatate, and gefapixant. Pratisha, right, absolutely right. Nilanjana, spot on. So when we have to suppress cough, right, we have three potential targets. If someone is coughing, to suppress the cough, we have three potential targets. See, one way of treating the cough is treat the underlying cause. Whatever is causing the cough, we can treat it. But there are other mechanisms. What we can do, we can either desensitize the receptors, right? We can block the cough receptors. So then receptors won't get triggered, cough won't be there, right? Or we can block the afferent or efferent nerve fibers. Or the third option is we can block the cough center itself. So your receptors may be working, your efferent may be working, but we can block the cough center. So when we block the cough center, the drugs used for that purpose, we call them as central cough blockers, right? Or central cough suppressants. What are the examples for central cough suppressants? The examples for central cough suppressants we have are narcotics like codeine, codeine, morphine. They are potent central cough suppressants. In today's practice, we do not routinely use them because they have the potential for abuse. Many of the patients who were prescribed codeine or codeine in the past often come back and say that they're coughing again, though their cough might be improved, they're kind of getting attached to it or addicted to it. So we avoid using them. But when cough is really bothersome, we do not have a choice. But we have an alternative central cough suppressant which has low addiction potential, that is dextromethorphan. That is why most of the over-the-counter cough suppressants contain dextromethorphan. Compared to the narcotic central cough suppressant, this has less addiction potential. Right. So right now, actually, I'm going through cold, and the tablet that I got from my home had dextromethorphan. Okay. Then the sensitivity of the sensory neurons involved in the cough reflex, that is C fibers or A delta, they can be reduced by the drug called as benzonatate. Okay. And in the very recent times, we have developed the drug blocking the cough receptor P2X3, and we call that drug as gefapixant. Gefapixant. So that would be the right answer for this question, because directly they're asking you what is blocking the P2X3. So we will go ahead with gefapixant as the right answer. Okay. So let me take you to the next question. Pratyush is absolutely right. Absolutely right. Okay. So in this, we have a 35-year-old who presented with cough of 18 days duration. 18 days duration. So what should I call this cough as? Acute, subacute, or chronic? Duration is 18 days. So should we count it as acute, subacute, or chronic? So Tapa, I will quickly revise the cough reflex after this question. So what is the definition of cough based on the duration? We categorize cough into acute, subacute, and chronic. So when it is less than 3 weeks, we call it as acute. 3 weeks is 21 days. Right? 3 to 8 weeks, we call it as subacute. And more than 8 weeks, we call it as chronic. That is a basic definition. Now let us get back to this question. This patient's cough started with sore throat and painful swallowing. Currently, he is free from throat pain, but cough continues to be disturbing. Chest X-ray and sputum culture are negative. What is the most likely diagnosis? So, what do you think should be the likely diagnosis? Young male, right? Gender not mentioned. Okay, let us presume there is a young male who has around 18 days of cough. So, right now it will be categorized as acute, but he is very close to be called as subacute cough. When the cough started, he had sore throat and painful swallowing. Now there is no sore throat, no painful swallowing, but cough continues to bother him, and it's very disturbing cough. Just X-ray we have done, does not show anything, and we have done the sputum culture, which has not grown any organism. So what is the most likely diagnosis? So I think this point I had given an elaborate discussion. Nowadays it's very common that once you get a upper respiratory infection or even a lower respiratory infection, there is a up regulation of cough receptors. Means the number of cough receptors, the TRPV1 and P2X3 increase. And because the number of cough receptors increase, even minor stimulation triggers cough. So even when they are trying to speak, small movement of air column inside the airway can trigger cough. See, this is a common experience. Many of our friends, sometimes we also experience, like, okay, we go through a sore throat. After that, we keep coughing for weeks together. All our classmates get irritated. Sometimes they try to maintain a distance thinking that, okay, I'll also get infected. It is not an infective cough. The moment your fever is over, no longer you have throat pain, no longer you have sore throat, you're not infective to others. Your infection is cured. Obviously, 18 days of sore throat, active infection, not possible. By that time, a person would have developed the bacteremia, septicemia, and even mortality if infection goes out of hand. Most people, immune system would take care of that infection. Now you're still coughing because your cough receptors are upregulated, and what we call that condition as post-infective or post-viral passive syndrome. So the right answer, as most of you mentioned here, would be option C, post-infectious passive syndrome. Cool. So that was Samantha. That's the point I'm telling you. Normally, what happens once we recover from infection, the cough receptors, right? During the period of infection, the number of cough receptors start increasing. So in our airway, for a few weeks, we will have higher number of the receptors for cough. And because of that, patient will continue to cough for minor stimulation, even while talking, or even slight movement of the secretions in the airway will irritate the mechanoreceptors and they will start coughing. And that is why in such patients, because they need a like few weeks of medication, either we prefer to give the central acting cough suppressants, but I will obviously be concerned about the risk of addiction. So that is why we had need for a drug, and in a recent times we have developed this drug gefapixant. So once it becomes more readily available, we will probably switch over from other cough suppressants to gefapixant for all these patients. Okay. So you were talking about cough reflex, right? So basically, cough is a reflex. What is cough reflex? It is a reflex which produces an explosive expiration. So we exhale air with an explosive force. That's how cough happens. Now, how are we able to do it? So this is a reflex, and generally when we talk about reflex, it will have three components: one, an afferent pathway, and different pathway, and a center. Right. So the afferent pathway for cough is the vagus nerve. Efferent pathway is glossopharyngeal, vagus, and phrenic nerve. And the receptors which actually get activated are the chemoreceptors or mechanoreceptors. Chemoreceptors generally send some abnormal chemicals in the air that we are breathing in. See, sometimes when you go to dusty environment, or sometimes when you go to some factories and all, you start coughing because those chemicals are sensed by these chemoreceptors, TRPV1 or 4. And sometimes, like, you have pneumonia, or you have interstitial lung disease, bronchiectasis, where the airway is being stretched in different directions by the fibrotic tissue, right? That, or you, by mistake, inhale, or some foreign particle goes into the lungs, right? Some foreign object. It's very common, especially in children. They keep coughing. Why? Because the airway is being stretched and the mechanoreceptors like P2, A3 are getting activated. Now, once these receptors are activated, they will send the signal through the vagus nerve, through A delta and C fibers, to the cough center, which is present in the medulla. The center is called as nucleus tractus solitarius. That center will send the efferent signals for the contraction of recessory muscles. That is glossopharyngeal nerve, vagus nerve, and phrenic nerve. Through these, the signals reaches the necessary muscles. What are the necessary muscles for an explosive expiration? I can only expire or exhale explosively if I keep my glottis closed, not allow the air to leak, and contract all my respiratory muscles. So I have to contract my abdominal muscles, I have to contract my diaphragm, contract my intercostal muscles, keeping the glottis closed. So that builds a lot of pressure inside the thorax. And then suddenly the glottis gets released, the opening of the glottis. Once the glottis opens, we will be able to exhale all that air at a very high velocity. And that is what cough is, right? This is what we call as cough reflex. Okay, so now let's get to the next question. Which among the following is the most specific symptom of left heart disease? Options are raised JVP, orthopnea, PND, and edema. Sankalp Maji, you should get used to, first of all, studying on a consistent basis, and you should give more time on your first year subjects. Because once you are good with first year subjects, second year and rest of the things start falling in place automatically. So the ideal time for you to start medicine is once you get into second year. First year, concentrate on getting your basics right. Anatomy, physiology, and biochemistry, they are the foundations of medical education. Spend your time with that. Right. So I think this point we had sufficiently discussed. So the raised JVP, I think all of us know, is a sign primarily of right heart dysfunction. Right. And we also know that the most common cause for right heart failure is indeed left heart failure. So anything that causes left heart failure can result in raise in JVP eventually, but it is not a specific sign, right? So this is primarily a right heart symptom. Okay. On the other hand, orthopnea and PND are features of left heart dysfunction, and edema can happen because of various conditions, not only cardiac, right? Renal, liver, and all other disorders. So all we have to do is choose between orthopnea and PND. Pratisha, absolutely right. So the JVP elevated, ascites, and pedal edema. These are cardinal symptoms of right heart dysfunction. Orthopnea, PND are cardinal symptoms of left heart dysfunction. So we have to only choose between these two which one is specific. And while discussing the dyspnea, I think I had told you that the orthopnea can also happen when we are having heavy meals, when we have diaphragmatic palsy. So there are various reasons for someone to develop orthopnea. It is not specific for the left heart dysfunction. On the other hand, PND is highly specific for the left heart dysfunction. So this orthopnea can be seen in patients with massive ascites, pregnancy, after heavy meals, as well as diaphragmatic paralysis, apart from left heart dysfunction. But PND is only or almost exclusively seen in patients with the left heart dysfunction, and that is why that would be the answer. Right. So I think all of you got the answer right. And the answer for this question will be C. PND is the most specific symptom of left heart dysfunction. And that's why one should know how to extract the history of PND from the patients. Okay. So we have two more questions to go. Here is one more of them. Sankalp Majid, see, the best resource is still the gold standard books. So think about it, how much time you can devote for the books. If you can devote good amount of time, then gold standard books are the best because everything else is a derivative. Even other Indian books, short notes, everything are derived from the gold standard books. If you follow gold standard books, your foundational knowledge will be very strong. If you do not get so much time, in that case, something is always better than nothing. So stick to the resource which you can complete in the time available with you and you can revise at least 2 times. Like if you don't have sufficient time and stick to gold standard books, you will never be able to complete, and then you will carry that backlogs throughout your MBBS. So choose a source which you can complete. That's more important. But if you have time, definitely go for gold standard. Okay. So which of the following statements indicate clinically important weight loss? So we had done one session on the weight loss, and definition is the most important thing. Okay. So multiple of these statements may be correct. So just go through the statement first. Unintentional weight loss of more than or equal to 10 pounds, that is around 4 or 4.5 kg over 6 to 12 months. Intentional weight loss of more than or equal to 10 pounds over 6 to 12 months. Unintentional weight loss of more than 5% of body weight over 6 to 12 months period. Okay. And then multiple combinations are here. What do you think? First statement is unintentional weight loss of 10 or more than that over 6 to 12 months. Second is intentional weight loss, same number, same duration of month. Third, unintentional weight loss of more than 5% body weight over 6 to 12 months period. So what do you think should be the right answer? Right, Nilanjana. Right. So here, statement 1, let us go by statement, right? Statement 1, is it part of our definition or the criteria for the clinically important or significant weight loss? Yes, right. That is how we have defined it. The weight loss definition that we did was exactly that. The first thing was weight loss of more than 10 pounds over a period of 6 to 12 months unintentionally. Second one was weight loss of 5% or more of body weight over a period of 6 to 12 months unintentionally. So if someone has intentionally lost weight, it is not clinically important. वो करना चाहता था कर दिया, right? Diet के exercise के he lost weight. I'm not bothered about it. But if someone is losing weight when he does not have an intention, obviously I'm concerned because something is there which is reason for the weight loss, and it is clinically important if he has lost more than or equal to 10 pounds. So first statement is very true. Second statement is false because this individual has lost because of his intention. Third statement is also true. So 1 and 3 are correct, and that makes option C as the right answer, right? Okay. So the last question for the day. A 60-year-old presented with headache since few weeks. Headache is worse on bending forwards and coughing, and is often associated with sudden bouts of vomiting but no nausea. Patient has noticed gait unsteadiness. What is the next best step in the management? I'm repeating again. Age of the person is 60 years. He presented with headache since few weeks. Headache is worse on bending forward and coughing, and is often associated with sudden bouts of vomiting with no nausea. There is no nausea. Patient also has noticed some gait disturbance. What is the next step in the management? Right, let me read the options for you. MRI of the brain is first option. Second, we should start him on NSAIDs for pain relief and amitriptyline for the prophylaxis. Third, start on triptans for pain relief and propranolol for prophylaxis. Or start on O2 for pain relief and verapamil for prophylaxis. So what do you think should be the answer here? So what is the approach for a patient presenting with headache? Step number one, right? Any person presenting with headache, first thing we have to rule out is whether it is secondary headache. If it is secondary headache, investigate for the diagnosis. Once you have ruled out the secondary headache, then we have to think of, if it is primary headache, what is my next step? If it is primary headache, you should see whether it is unilateral or bilateral. If it is bilateral, we know it is tension type of headache. If it is unilateral, it could be migraine or trigeminal autonomic cephalgias like cluster headache or the paroxysmal hemicrania or SUNC or SUNA. So further discussion, obviously there will be additional clues in the question as well as the duration of episodes of headache holds the key for the diagnosis of primary headaches. So now in this question, what do you think? This is secondary headache or primary headache? That's the first step, right? Pratyusha, I think yes, you're getting the point right. So Nilanjana, do you think this is a tension type of headache? How do I get to know whether a person is having a secondary headache? By looking for what we call as red flag signs, right? So I think we had made a list of important red flag signs. The list can be expanded further, but just let me read through what we had covered in the red flag signs. How to approach a patient presenting with episodic headache. Rule number one, step number one, rule out secondary headache by ruling red flag signs, right? So if red flag signs are there, we need to investigate. So first red flag sign in this question, age of the individual is 60. Generally, if someone past 55 presents with headache, we should always count it as secondary headache, rule out, then come to the possible diagnosis of primary headache, right? Then second, he is vomiting, and I had told you specifically how to differentiate between projectile and non-projectile vomiting. Most importantly, in the projectile vomiting, there will be no nausea, and in the non-projectile vomiting, there will be nausea. So in this question, the patient has no nausea. That means he's having possibly projectile vomiting. And when someone has projectile vomiting, what should come to our mind? We should always think of raised intracranial tension, right? Raised intracranial tension. So there are like multiple pointers in this question for me to think of raised intracranial tension. First, age is a red flag sign. Projectile vomiting is a red flag sign. And third, patient has got some neurological disturbance, that is gait unsteady. He has balance issues. So all of these are red flag signs. So when we have red flag signs, we don't make a diagnosis of primary headache. Don't think of migraine. Don't think of tension type of headache. Don't think of trigeminal autonomic cephalgias. Rule out the causes for secondary headache. So among the options, what makes sense here? What should we do? Right, making imaging of the brain makes the right choice here, right? It could be CT or MRI. Here there is no option of CT, so obviously the remaining option is MRI, and that is what we will choose as the answer here. Okay. Now, in the remaining options, let us just quickly understand for what circumstances they become right answers. So option B, start with NSAIDs for pain relief and amitriptyline for prophylaxis. What would be the diagnosis for this option to be the right answer? What could be the diagnosis for this option to be the right answer? Nilanjana, no, this is not a case of tension type of headache, right? So only when, okay, if I just rephrase this question and say that MRI is done and that turns out to be normal, then maybe you can start thinking of the primary headache disorder. But till you rule out, it is a secondary headache disorder. बहुत कुछ pointers है, right? Gait unsteadiness, projectile vomiting, age more than 60, all are red flag signs. So पहला thought क्या होगा? This is secondary headache. So in this question, our diagnosis will always be secondary headache first until and unless I rule out with imaging and other required investigations. Right. So the statement B makes sense for which disorder, which type of headache? Right. I think this is B would be suitable for a patient with tension type of headache, right? Tension type of headache. Tension type of headache, the drug of choice for acute treatment or pain relief is NSAIDs, and for the prophylaxis, it is the tricyclic antidepressants like amitriptyline. Now, this next option, that is C, right? It will be the ideal answer if the question was talking about which type of headache. Start on triptans for pain relief and propranolol for prophylaxis. Right. So that is obviously for migraine. That will be obviously for migraine. Migraine, acute treatment, drug of choice is triptans, and for prevention, beta blockers like propranolol. And option D, start on oxygen for pain relief. Oxygen is the drug of choice for acute treatment of which type of headache? That is cluster headache, right? And in case of cluster headache, we have two levels of prophylaxis, the short-term prophylaxis and long-term. For short-term, we use steroids. Long-term, we do consider using verapamil, right? So option D will be the right answer if the question was talking about cluster headache. If the question was talking about cluster headache. Awesome, Nilanjana. Very good. Very good. So this is what we had for today. 7 questions. I will be sharing 10 more questions on a PDF with the Telegram. So all those also, they are also based on the similar topics that we have covered, and the topics that we have not attended so far will be covered in the next MCQ batch. And after that, we will get back to the regular series. So with that, I'm signing off for today. I'll see you in the day after tomorrow's class. Till then, have a good day.